Thanks, Natalie, very much. I'd like to echo David's both thanks and compliments to Anne and the advocates for putting on days like today. It's you can't underestimate how important it is for all of you. It's an opportunity to not only come together and meet each other, but also an opportunity to meet us a little bit more informally. And Natalie and I met for the first time yesterday and realised that we had 2 degrees of separation with our siblings based in Tasmania. And I think that's what the beauty about days like today are. So thank you for all of you taking out your time as well to attend today's session, and we hope together that we can provide you with some insights, but perhaps more importantly, not only empower you, but act as navigators and chaperones through the minefield of what's out there on the internet in terms of MPNs. You'll find that today there'll be a lot of overlap with many of the talks, and I think that's possibly a good thing. You'll hear different slants on the way we describe things, which I think is really helpful. We'll be a bit like Brownian movement and probably bounce off each other, and hopefully you'll gain the insights that you need individually in terms of your journey with an MPN. The title I was given is Risk and Disease Burden, which is just a fairly educational topic, and I didn't feel the need to change it, but I also feel I wanted to change it because I don't want to talk about it as a risk and a disease burden, because the whole point of today is realising how you live with MPNs and that it doesn't define you and it's not a risk and a disease burden. And I don't want you waking up every day going, oh God, my blood count looks like this, but I feel, what should I feel? I want you to feel well, and I want you to be able to wake up every day and make every day count and be a good day. And I think you'll hear a lot about that today. So what I'm going to talk about is a little bit of what it is, and David's already covered a lot of this for me, which is fantastic. But then perhaps how you can move forward in terms of your journey with MPN. When I meet my patients, I tell them that blood's the most important thing in their body, and it's not because we're blood specialists, it just is. So David's already walked you through some of the blood cells, and I'll walk you through a little bit more. So we know that it comes from our bone marrow, and if you snap open a chicken bone or a steak bone, you've got all the marrow and mush on the inside, and we've got that on the inside of our bones as well. And many of you in the room today probably will have had a bone marrow biopsy and had a little trocar or an apple corer put into your bone to sample this. And Wendy will talk a little bit more about what it looks like down the microscope when we look at your bone marrow in the next talk. So we have red cells, white cells and platelets, and David's already introduced you to many of those blood cells, and your red cells are your petrol in your tank. They carry your oxygen and your nutrients and give you energy, and that's the one that's elevated predominantly in polycythemia for those of you in the room with polycythemia. Your white cells are like your layer of defence. Your best defence are your linings, your skin, and the linings on the inside that keep the bugs in the outside world. We don't like to think about it, but we share this world with bugs and toxin. So they're there to keep your trenchmen to keep you safe. And your platelets are like your sealant glue, and they're the ones that are elevated in those that have essential thrombocythemia predominantly, as well as a spectrum across the board, as David said. So these are all generated in your bone marrow. But I want you to take you back one more little step, and when you think about it, we all come from a single cell. And that single cell has the same genetic blueprint as every cell in your body that exists today. And that single cell managed to become brain, heart, lungs, muscles, nerves, and blood cells. It's quite phenomenal, isn't it? That single cell has a genetic blueprint but can actually transform into whatever cell you need. And what many of those stem cells are doing in your lifetime are making blood cells every day of your life. And what there essentially is in this stem cell is a light switch on your bone marrow, as David alluded to and talked you through some of those light switches. And every time you need a new blood cell, it makes a new blood cell, essentially. Red cells live for about 3 to 4 months, white cells can live for a variable amount of time, and platelets only live for about 5 to 7 days. So this marrow is the busiest blood-making factory that ever existed. And so there's a switch on your marrow that says you need more red cells, white cells and platelets. And sometimes that happens for physiological stresses. You might get sick from an infection and you need more white cells. I described to someone that I met yesterday, if you lived at the base of Mount Everest where the air is thin, you'd make more red cells. So there are natural physiological mechanisms that the marrow makes more blood cells. And then, of course, what can happen, as for many of you in the room, the light switch gets turned on. And this light switch turns on and you start making blood cells even though you don't need them. And that's essentially, as David's articulated, what a myeloproliferative neoplasm or disorder is. We now understand a little bit more about the light switches, and you've heard about Jack and CALR and MIPL, and you'll hear about those terms throughout the day. And these are the aberrancies that have gone and turned on the switch to encourage your marrow to make more blood cells than you need. And depending on which blood cells you're making, you sort of fit into one of these diverse categories, phenotypically or biologically. And David's already shown much of this, and according to what is your predominant syndrome, whether it's red cells, white cells, platelets and a spleen enlargement, we categorise you as polycythemia, chronic myeloid leukemia, essential thrombocythemia, and indeed myelofibrosis. But the principle of what's happening biologically is the same. The light switch on the marrow has been turned on and it's preferentially channeling down one of those lineages. And of course we have some other myeloproliferative disorders that we don't tend to spend much time talking about, and they're a lot rarer, but they include the other cells that are made from our bone marrow as well. It is quite rare, as Anne said, but not that rare. You know, there are plenty of people in the room today, and there are plenty of people in Australia and around the world that meet us for this reason. And I agree, Anne, it's no longer a diagnosis of the 60 plus. I've got many more patients now from the age of 20 up to 35 and 40 that are gracing me in my clinic room, as my colleagues are. I always get asked, why has this happened? And if we knew why anything happened, diabetes, rheumatoid arthritis, I think we'd have the crystal ball for many things. But we don't know. It's nothing that you've done. And it's not been handed down by your family necessarily. There is a predisposition in some of them. But it's just the way the blueprint in your genes have been transcribed over a lifetime. And we know that there probably are many environmental influences in this concept of epigenetics, which I'll come back to. David's already walked you through this, so we look at blood counts, we look at your marrow down the microscope, we do genetic and molecular tests in order to diagnose it. Again, Wendy will talk you through some of the mechanisms, but just to give you an idea, when we go and take the sample out of your bone marrow using a bit like an old-fashioned apple corer, but it's about the size of an inner pen, and it goes into the marrow and takes out the samples, and then we go and test them and look at them under the microscope and send them for genetics. I thought I'd start with this because, you know, I think when they mapped the Human Genome Project, which they essentially did by the early 2000s, they thought it was going to be a discovery inwards, and we'd have this transformative blueprint that would answer our questions. We'd know how to diagnose, prevent, treat and cure. And of course it was like the Hall of 1,000 Doors, and as soon as we'd mapped the blueprint, we realised that we didn't even begin to understand how the blueprint was transcribed, and we know that there's more than 20,000 genes that exist in this blueprint. And, you know, at any one time they're upregulated, downregulated, changed, and this is really the power of what we are as people, and also why things happen as we go through life. I mentioned to you that these embryonic stem cells have the capacity to differentiate into any tissue in your body, and that's a form of epigenetics, for want of a better description. It just means upon genetics. And these cells, although they have the same blueprint, they can then transcribe into whatever cell and tissue that you need. And we know that identical twins become less identical over time, but we also know that identical twins that didn't grow up together share very much similarities but differences as well. And so now we know it's not just about the blueprint, it's about how our genes are transcribed and how the messages come through. And that's one of the phenomena that happens with myeloproliferative disorders. As David said, it's always nice to look backwards and see how far we've come. And since David's already paved that for me, really what I want to do is say that, you know, over the last, or between the mid-1800s to early 2000, we didn't make a lot of ground in terms of understanding the pathogenesis, but really in the last 5 to 10 years, there's been huge headroads. The landscape has expanded substantially, and I know there's huge unmet needs for all of you in terms of understanding and moving forward with treatments, but the amount of growth that we've had in the MPN field in the last 5 years is genuinely exciting. It's exciting for us as clinicians that work with you, and hopefully exciting for you as patients looking forward, and hopefully that we'll understand this even more and more and have opportunities for you in terms of moving forward. CML was really the front runner, and the reason I put this slide up is just to show you that CML is very simple in design. And as a result, it's a simple translocation of gene material that creates a protein that upregulates the marrow, turns the switch on. And again, when this was discovered, we thought we'd have the answer to everything. And in the Time magazine in 2000, they said, the war against cancer. We've discovered it. We know exactly what to do. But as we know, with unlocking the code with MPN, it looks a little bit more like this. But we're starting to unravel it, and I think what's great is, you know, slides like this were designed probably 10 years ago, and now we understand more and more what these specific genes and signalling pathways are. We know it's not just about the JAK mutation, and that's even huge headroads in itself. When the JAK gene or JAK2 gene was discovered in 2005, again, we thought we had another CML. But I think we're making great progress, and I think for all of you in the room, you should be excited by this. This is, again, just to give you an idea about epigenetics. And, you know, if you were going home yesterday at the end of a busy working day and dinner was going to be cooked for you and the house was going to be clean and you're really excited to get home, and there was a roadblock in front of you, you're not going to pull up stumps and go, damn it, I'm going to have to sleep here the night and freeze to death in my car. You'll find another way. And that's what happens in our body. Cells try and survive. And so the more we understand about this, the more we can move forward. And I think that's fantastic. So I should really move on to what I'm really here for, and I promise I won't go over time, Anne. But what do we mean by the David, you should be very wise to be frightened of 5'2" women. You're in good company today, Anne. I'm with you. So when we talk about the disease burden, and Anne's really touched on this beautifully in our opening slide, it's not just about the symptoms, or it's not just about a big spleen. It's also about meeting doctors for the first time. Many of you probably had a blood test because you were deciding to start a family, or you wanted a healthy check, or work mandated it. And then suddenly someone turns around and says your platelet count's 800, or your haemoglobin's 200. You've never met a doctor in your life, and then suddenly you're walking into the doctor's room, they're telling you have to have a bone marrow, all these blood tests, come and see me every 3 months. It completely turns your worlds upside down. And I think probably Cecily will talk about this a little bit this afternoon as well. So the disease burden, in inverted commas, what I want to touch on is not just your symptoms, but what the impact has on you as people and your relationships and the conversations you have with people, as well as the consequences. So what are the symptoms? You know, many of you probably don't have any symptoms, and I think that's fantastic. And Ken, I don't think you'll mind me saying this, but when we met him yesterday, he said, I was diagnosed with polycythemia 20 years ago. And you look at him today and he's fit and healthy and enjoying life, and I think that's wonderful to see. And I think that should be really empowering for many of you in the room. So most people are asymptomatic, but some people do have symptoms attributable to all of the mechanisms that we've talked about this morning. And it can be from enlargement of your organs, it can be through sticky blood and high blood counts, but a lot of it is just due to this chronic inflammation in your body and that profound fatigue. And there's a spectrum across all of them. And I think if you looked at a slide like this, all of you'd probably pick out 1 or 2 symptoms that might be relevant to you. And probably the most important one is that just body fatigue, being able to get up every day and do what you need to do. I think the itch is an interesting one. We, have some insights in what drives it, but we don't have great remedial measures. I don't know if any of you've had one of those itches, but when it's that recalcitrant itch that you just can't get away, it's not going to hurt you in any way, but it can be very morbid for people that have recalcitrant itch. And again, it's a very diverse symptom profile, and hopefully what most of you experience, it's not every day, but it's definitely there with you. So again, this just talks about the consequences of increased inflammation. And I think particularly for my young women with young children, it's exhausting running around after the children at the best of time, but also with this. And in fact, we're very lucky to have Ruben Meeser here, and he's really both the pioneer and the front runner in terms of unravelling symptoms for us in our patients. And we've learned a lot in the last 10 years, what matters to you. And really, what I'm showing you here are symptoms reported by people just like you in huge studies, thousands and thousands of patients. And I'm sure many of you can relate to some of these symptoms. And what's fascinating is it really doesn't matter what category you fall into, whether it's polycythemia vera, ET, or myelofibrosis. The symptoms are very similar across the board, just vary in their degree. But that early fullness when you're eating food, fatigue, not being able to sleep properly, and hopefully we're getting better at managing those symptoms for you so that you can enjoy life. And again, this is work again from Ruben that was presented a couple of years ago at the American conference, but just to show, compared to the general population, the disease burden and what impact it has on you on a day-by-day basis. One thing I found really interesting again from Ruben's work is the difference between males and females, and it doesn't matter where you are in the world, whether you're Chinese, American, Australian, this stands true. This is not because the female or the weaker race, the men in the room, I'll just put that there, but they are definitely younger, have a much more higher level of fatigue, present with more abdominal symptoms and so forth. So there's definite differences between men and women that we're starting to unravel, and that also provide insights into the pathogenesis behind myeloproliferative disorders. What matters? Well, really what matters to us is what matters to you. But it's really intriguing if you ask a doctor and you ask a patient what matters in terms of their symptoms. You ask us and we'll say, we want to prevent clots, we want to make sure your blood counts stay healthy, we want to make sure there's no end organ dysfunction. We ask you what matters, and it's about quality of life. It's about being able to get up, do your job every day, be with your family, go out with your friends, have genuine conversations about life and not feel tired. So I think this is really insightful for us as physicians, as well as insightful for you as patients as to what matters. Interestingly, if you ask polycythemia versus ET, again, they're very similar in what patients report as matter to them. Yes, of course you want to slow or delay or prevent any progression of your disease, and you want to prevent medical complications, but also it's about symptom control and quality of life. What about the impact of living with myeloproliferative disorders? How many of you are still trying to hold down full-time jobs? Probably most of you in the room, yeah. And this was really interesting, how many people had to actually change their employment or de-escalate their employment, take time off work. How many times do you have to take time off work to come and see us in clinic, have bone marrow biopsies? So we do intrude in your world. So what we're here to do today is to try and empower you and regain that control and know how to live with MPN. And again, this is just some more data showing you that if we really ask patients what's happening in their world in terms of MPN, it is really important. Vascular risk does matter, although it's not something that you can see. I have shown pictures here, but a bit like David said before, it's not something that you can see when a blood vessel clots off. I said to you, blood is the most important thing in your body. If you block the plumbing, that's equally important. So we do worry about this, and that's why we put many of you on aspirin, and indeed it's why many of us start treatment with you to prevent these major complications. We know that in MPN, the vascular risk can be substantial and in fact a very important event. And in fact, we now understand a lot more about why people with myeloproliferative disorders do clot. And a lot of it's to do with the JAK mutations and other mutations driving inflammation in the body and driving the blood cells. And we now have nice profiling so that we can look at you as individuals and say, well, if you optimise your risk factors, make sure you have a healthy body weight, control blood pressure, non-smokers, and whether or not you're JAK2 mutated or not mutated, and actually tell you what your risk is and be able to devise a personalised program in terms of preventing vascular risk in your body as well. So we're making huge headroads in terms of understanding. We know that JAK mutation is one of the most potent prognostic factors for vascular events. And it's interesting, in those that are CALR mutated, they have higher platelet counts, which you'd think would confer a greater risk of clotting, but in fact it doesn't. So we're understanding more and more about this, and similarly with the MPL. Platelets, Wendy will probably talk a lot more about platelets, so I might just move on from that. But we know there are a lot of mediators of clot production in myeloproliferative disorders, and we hope that some of the treatments going further, particularly things like JAK inhibitors, and some of you might be on ruxolitinib, will actually have a great impact in terms of preventing vascular events, particularly in those that have had events before. I don't know how many people in the room have actually had a vascular event. You don't want to have it again, do you? No. So this is a really important aspect of our care for you. So what is the true impact of MPN? Living with MPN, it's a chronic condition. As David said, it's not something you can cut out and make it go away. But you can live with it, as you know, and you're all living proof of that and being here today. We certainly understand a lot more about what the impact is for you from a symptom perspective, physical, emotional, and how it defines you. How it impacts not just you, but your family and all your significant others. How it impacts conversations in life. You don't want to have to wake up every day and talk about it, and so it's really important that your significant others also understand what this journey is for you as well. Impact on occupation, it's really important that your people you work with and your managers all understand your journey as well, and what the financial impact might have as well in terms of attending medical appointments, having medical tests, being on therapy, all of the things that impact you now on. Being captured medically, you know, as I said, many of you were asymptomatic, you probably never met a doctor in your life, and now all of a sudden we're asking you to see us on a very frequent basis. As well as the therapies, and some of you might be on therapies in the room, and the impact that has on you on a day-to-day basis. So all of this contributes to what I call the impact and the disease burden in MPN. And when we're searching for answers, and I apologise to the US people in the room, but you can't help but look to the US presidents and politicians for a bit of humour. So Donald Rumsfeld said this when he was trying to explain the Pearl Harbor, because as you know, there are known knowns and there are things that we know. We also know there are known unknowns. That is to say, there are some things that we don't know, but there are also unknown unknowns, the ones that we don't know, we don't know. And he said this when he was trying to answer to the Secretary of Defence, and everyone just looked at him strangely, and we've all seen pictures of Donald Rumsfeld. And then we go further afield and there are whole Bushisms on the internet, I'll just let you know that, and then, of course, there today. So anyway, moving back to MPN, I think, the future is bright. So what are our known knowns? I think we now have a much greater understanding of the diagnosis, classification and stratification. You'll hear more about this today. We have a much greater understanding of the mechanisms driving the process. We've come so far in the last 10 to 15 years. We're now getting actionable and druggable targets. I know there's areas of unmet need and we want more opportunity for this, but certainly we've made huge headroads. There's a much greater appreciation of what matters to you, and you'll hear more about that throughout the day. There's a much greater understanding of your symptoms and how we manage them, which is probably the most important aspect that we can gather. And I think the future is opening up for the MPN family, and I think the best is yet to come. And so I think you should feel optimistic in terms of your care moving forward. And I think today's like today are an example of that, of people like Anne and her team making huge efforts to empower you and open up the world so that you can access information and meet each other, which is more important than anything else. So what about the known unknowns? Yes, we still have a lot of information to gather. We still need to understand more mechanisms. We still need to understand what treatments are best for you and when we bring them in. You don't want to go on hydroxyurea until you need to. We need to know whether, utilising ruxolitinib earlier is better for you. So these are some of the known unknowns that we're working hard with our colleagues and our clinicians and researchers to answer for you. We need to know if the combinations might be better, and again, there's lots of efforts moving forward in this, and you'll hear more about that this afternoon. So there's definitely a commitment of expertise and research, and you'll see that from days like today, which I think is fantastic. And there are always going to be unknown unknowns, but I think there's less of that than what there was even 10 years ago. And so certainly it is more optimistic for people living with MPN, and I'm hoping that all of you today witness from that by being present today will find more insight, empowerment and confidence after days like today, with many more to come. So what matters most, as I said, you guys do. So we're very happy to be here for you today. It's about you. We're happy to answer any questions, as Anne said, throughout the day. And I thank you both for attending today, as well as your attendance with this talk. Thank you.